Next speaker, Dr. Lakshmi Madam. She is the Associate Professor working at Malabar Medical College and works as a consultant pediatric ophthalmologist at Abate ACE Hospital. She'll be talking on avoiding the unexpected twist, strabismus evaluation in a patient undergoing refractive surgery. Over to you, madam.
Thank you. So, strabismus and binocular single vision evaluation in a patient undergoing a refractive surgery. Why is it so important now? So, with increasing amounts of patients undergoing presby-LASIK and monovision, and post-squint surgery patients undergoing LASIK, and increasing amounts of LASIK in hyperopia and anisometropia, it would be a very unpleasant nightmare to have a postoperative double vision or a non-strabismic binocular vision abnormality in the postoperative period. So we'll just have an overview of what are the common causes that produce these issues in refractive surgery. So this is the first case of 45 years doctor using progressive glasses, myopic astigmatism in both the eyes, and he complained of double vision. He gave a history of strabismus surgery being done after 18 years and LASIK at around 30 years of age. And on cover test, there was no deviation, ocular movements were full, and his best corrected visual acuity was 6/6. So he had something called a fixation switch diplopia, which is something which the patient experiences when the patient is forced to fix with the non-dominant eye. So he had undergone a squint surgery and then a LASIK, and his non-dominant eye was overcorrected, so he was forced to see with the non-dominant eye. So we managed it with giving him an undercorrection of the non-dominant eye, so he was able to get away with the double vision. The second scenario is a 23 years IT professional wanting to do LASIK, and she had myopic astigmatism with a well-compensated large angle exophoria. She had asthenopic symptoms, and on cycloplegic refraction, we found that she had an overcorrection of her myopia. And even after the optimal correction, she happened to have an accommodative excess with a continuing asthenopia. So the problem in this condition is, if she goes ahead with a LASIK, in the postoperative period, she will have this accommodative excess, and this might result in a false impression of a regression of myopia after LASIK. So this is called pseudo-regression. This could be prevented because she is still on therapy for her accommodative excess. So iatrogenic monovision in patients having strabismus and undiagnosed non-strabismic binocular visual acuities like our second patient, a missing of the history of prism use by the patient, anisoconia and technical issues are the common problems that we face in this situation. Technical causes, of course, is a decentered ablation zone which can cause a prismatic effect and a vertical phoria or a pre-existing deviation decompensation. Latent squints per se is not a contraindication for LASIK or refractive surgery. Accommodative esotropia, latent strabismus and intermittent strabismus, those patients are increasingly doing LASIK, but we need to take care of certain issues while dealing with these patients. Decompensations have been reported. So how to go about these patients? Cycloplegic refraction and preoperative orthoptic evaluation, like I mentioned earlier, is essential. Detection of mild amblyopia and dominance of the eyes should be taken care of. Binocular single vision assessment preoperatively should be done. And even in adults, cycloplegia might be required to rule out an overcorrection of the myopia. And contact lens trial in patients having intermittent squints could give a help in how these patients might behave postoperatively, and consecutive treatment of first the dominant eye and then the non-dominant eye for refractive correction would help in preventing this fixation switch double vision. And we have the battery of orthoptic evaluation tests to perform in these patients. The next thing I would like to mention is angle kappa. It might be important in LASIK, PRK, multifocal IOL patients. Decentered ablation zones will cause irregular astigmatism and prismatic effects. photic phenomena can be seen in multifocal IOLs if angle kappa is not diagnosed previously. So what is the problem with angle kappa? The first picture above is large angle kappa, and the centration zone, this is the corneal entrance light reflex thing, and this is the ablation zone. So if they have a positive angle kappa, this results in a decentration of the ablation zone. So that has to be taken care of. Even in the postoperative period, young patients need to undergo an orthoptic evaluation and rule out non-strabismic binocular vision abnormalities before stamping them as regression of myopia. So to summarize, a preoperative refraction, including a cycloplegic refraction, preoperative orthoptic evaluation, binocular single vision assessment, avoiding monovision in anisometropia or intermittent strabismus patients or post-squint surgery patients, centration techniques in refractive surgeries, LASIK, and post-operative orthoptic evaluation may do a large job in preventing such unexpected twists in refractive surgeries. So thank you.
Thank you, madam, for that wonderful talk.